Everybody, thank you for the pictures. Okay, well, we're honored to have Dr. Marc Perlman with us today. Mark, tell us a little bit about your educational experience, please.
My education experience?
Yeah.
Oh, so I went to college upstate New York, a small little liberal arts college called Union College. There I got my bachelor's. I also got my MBA from Union Graduate College there, and then I matriculated to Albany Med, 4 years in Albany, New York, and here I am. So today I'll be talking about a topic that is a little bit taboo, the idea of supplements, their role in modern medicine from a patient perspective, from a physician perspective. We've all been there before. A patient says they're taking something we haven't heard of before, something like an ashwagandha or a black cohosh. What do we do with a patient that has that? Are supplements poison pills or panaceas? Are they snake oil or are they saving graces? Let's jump in, let's talk about it. Hefty agenda here, but I'll make sure we go speed through everything. First, we'll talk about some definitions. What is a supplement? We'll talk about the FDA role in safety and regulation. We'll talk about the approach to a patient, how to negotiate, how to counsel a patient on supplements. We'll talk about some common supplements that I think everybody in this room should be aware of. Then we'll have a little bit of a summary at the end and some key actionable takeaways. Who's ready to get started? Woo! All right, put on the seat. So, I have no conflicts of interest to disclose, I promise.
Yeah.
Okay, so what is a supplement, right? We think it's usually a pill, a product that is added to the diet, a nutritional supplement taken by mouth, usually contains one or more ingredients, vitamins, minerals, herbs, amino acids, and enzymes. But when I think of, that's the general definition. When you think about it, there's a lot of additional substances we're putting in our body that we don't necessarily think about. So we have, just lighter word, yeah. So we have pills and tablets on the left. In the middle, there are gums and different kinds of ways to take those typical swallow supplements. But we also have like energy drinks that have tons of nutrition and supplemental stuff in them that are pharmacologically active and that could interact with the patient's medications or disease state. Furthermore, something like cereal, right, that we buy for our kids, it has a numerous amount of vitamins and minerals that tend to be fortified. But the question is, if we're saying they're part of a balanced diet, are these the most bioavailable forms of those minerals? There are additional considerations when it comes to just trusting a nutrition label. So why do we care about supplements? We care about them because our patients care about them. And that's evidenced with the financial markets. So per the 2023 Consumer Survey on dietary supplements, nearly 3/4 of US adults take dietary supplements and more than half of them identify as regular users. From 2007 to 2017, the prevalence of dietary supplements use increased among all age groups of US adults. The use of 2, 3, or 4 or more dietary supplements increased with age, while the percentage of adults not using any dietary supplements decreased with age. So as we get older, we tend to want to put more stuff in our body, which coincides with the fact that you're more likely to have polypharmacy the older you get. Dietary supplement use increased with age, as we discussed, overall in both sexes, and was highest among women aged 60 and over. So why have supplements become so popular recently? Well, there's an increase in health awareness. The aging population has growing health demands that make them more complex as we test for more things. E-commerce growth and accessibility has made it easier than ever. Back in the day, you had to get your supplements from GNC or CVS. Now you can click a button on your phone and have supplements delivered to your door with minimal effort. Similarly, there are very palatable ways to take supplements these days that have cherry melatonin and grape melatonin. There are gummies, drinks, sprays, lozenges. This has expanded the market of who typically identifies as a supplement taker. More interestingly, over the past few years, with the rise of the COVID-19 pandemic, there's been a growing distrust of organized medicine. People are looking for an answer, and oftentimes it's in the supplement aisle of the drugstore. So a well-balanced diet is the best source of micronutrients. However, three-quarters of the U.S. population does not consume the recommended intake of fruits. 80% don't take the recommended intake of vegetables, as well as many don't take the recommended intake of whole grains. Even if they did get the recommended daily allowance of, of these ingredients, industrial agriculture and its ultra processing of food makes this food nutrient depleted. And ultimately, half of Americans are deficient in a critical micronutrient. So there's a one criteria to measure classification of processing foods called the NOVA system, and here's a classic example of it. So on the bottom left, we see apples fresh from the tree, right? And as you go to the right, they become more and more processed and lose more of their nutrients as they go through. From prepackaged apple slices to sugar sweetened applesauce and apple fruit pies. Every step in the journey, they lose all that fiber, they lose all the nutrients. So when should we actually consider supplementation of patient? Well, if they have a serologically confirmed deficiency, such as low vitamin D, low B12, if they have poor absorption from a GI disease like a pernicious anemia or a celiacs, if they have poor general peel intake, such as potentially patients that suffer from alcoholism, restrictive diets like veganism, vegetarianism, or the ketogenic diet, or patients that may have greater nutrient demands that their diet can't necessarily tolerate or sustain, such as potentially pregnant people, extreme athletes, or ICU patients. Having just come off of the ICU rotation, nutrition is an extraordinarily complex science for these critically ill patients. So we talk about the benefits of supplements, where they're indicated, and we talk about some of the risks. But what exactly is the safety of supplements? What kind of regulations are there? So the Food and Drug Administration loosely oversees supplements. There's no pre-market approval required for a supplement. There can be action taken after a supplement is on the market after there's evidence of harm. A supplement is not required, or supplement company is not required to prove effectiveness. It cannot claim to treat, diagnose, prevent, or cure a disease. They must follow good manufacturing practices, but they're not routinely tested by the FDA for purity, so it could contain stuff that's not in the label, and dosage could be remarkably off. We'll talk about some case examples in a little bit. These supplements must, or the supplement packaging must include a supplement facts and a disclaimer that the FDA has not evaluated them. But one loophole around that is supplement companies can include a proprietary blend as their main ingredient. And because it's proprietary, they're not obligated to share the facts. So a lot of these elixirs that claim they solve something, oftentimes it's proprietary blend, which has a host of potential ethical dubiousness. So what are some dangers of supplements? Here's a short little list here. We have drug-induced liver disease is probably the first to come to mind. Case fatality rate is 10 to 50%. It's very difficult to actually get a prevalence or incidence daily because it's remarkably difficult to determine causation. Most common culprits include turmeric supplements, kratom, green tea extract, Garcinia cambogia. Another danger of supplements is that you can have super therapeutically toxic levels of otherwise physiological substances, something like zinc, right? At physiological doses just from our diet, it's relatively safe. But if we're taking, 100 times or 10 times the amount recommended for the supplement, then that could be harmful. Supplements can also interact with medications via cytochrome systems, like St. John's works, that classic board style question. So I think it's important to realize that supplements are pharmacologically, medically active substances that have potential to harm patients. So when discussing a supplement with a patient, it's really important to figure out a patient's strength of attachment to where they're coming from. Oftentimes, a patient will start a supplement and they'll feel great, or maybe they'll feel nothing at all, or maybe they have a family member, or they read a newspaper article, or some ad on TV that told them to take something, and they're really interested in taking that supplement. It's very important as we counsel patients to be aware of the strength of their attachment because it can lead to something called reactive polarization, where they actually become even more tied to that fear. So I have a little picture of the trans-theoretical model of change, which I use to adjust any lifestyle or medical change to a patient. You want to see where they are. Are they pre-contemplative? Are they contemplative? Are they in the preparation stage? And you tailor that to their specific disease state and the intervention they're working towards to help them get to the next stage. Not necessarily get them to the action stage of stopping or starting something, but to transition them to the next stage is the best that we can do for them in a limited time. My approach to supplement interventions are to address STEP, safety, tolerability, efficacy, and price. Of those four, the most important is safety by far. Our first job as a physician is to do no harm. So as long as a supplement is safe and it's not going to harm the patient, then I think it's generally okay if it's tolerable, plus or minus efficacious, and it's not going to rob the patient's bank. So it's okay to establish a verbal contract with the patient to check for known side effects, such as LFTs in a patient's taking green tea supplement, creatine function in the supplements known to cause kidney issues. Especially as a baseline, I think it's critical to test those things in known supplements that have those known effects. I really want to talk about this psychological concept known as the Dunning-Kruger effect here. The Dunning-Kruger effect has knowledge on the x-axis and confidence on the y-axis. So as you get more knowledge, you start off as a novice, not knowing much. You Google a couple articles, you go to WebMD, and you think you're an expert, and you're very confident. Then you learn a little bit more, and a little bit more, and a little bit more, and you learn that actually it's probably more complicated because at the end of the day, truth is very hard to come by. As you get more knowledge, your strength of opinion goes up to a more realistic level depending on how much you know. So I think this is very important when discussing patients because patients may do a little bit of research, right? They may have a trusted source and they need to be at the peak evidenced by the Dunning-Kruger effect, where they are still ignorant of the actual consequences of their supplement. So a couple of points to highlight here is overconfidence. If the research isn't thorough, lack of awareness of the risks of their action. Every time you make a decision, there's a subliminal calculation, a calculus of the pros and the cons. And oftentimes, people underestimate the negative downsides of the decision and potentially overestimate the upsides of the decision. So here's some practical tips to take away for a negotiating supplement with a patient. So I would encourage a patient to keep a lot of relevant data. If they're taking a supplement that helps with bowel health, have them report how many bowel movements they had a day, right? How have they changed in appearance? Only make one change at a time. When starting out, a patient is perfectly reasonable for a patient to take the supplement every other day or take it for a week and then kind of do an internal crossover study. Take the most bioavailable form of a supplement. Prefer taking supplements with third-party testing. Minimize brands with artificial colors, artificial flavors, or added sugars if possible. And one resource is examine.com. This is a free site for providers or for patients to look up supplement brands to see what they're really containing, if they're third-party tested, dosages, contaminants, that kind of thing. One of my strong recommendations also is to avoid multi-component supplements. So I would not recommend a patient to take a supplement with more than one or two ingredients in them because that can conflate the waters if you're looking for an effect. Also, routinely get labs checked if able to at least annually. So if you're taking a magnesium supplement, it probably would be prudent to check magnesium levels at least annually in that patient. So when you walk into a drugstore, the supplements are organized based on effect perceived by the patient. So there will be an immune health section, a sleep section, heart health, so on and so forth. So this is how patients generally make decisions. They often go, they're maybe at the store for something else, and they see a sign that says sleep. Okay, so then all the brand marketing comes to play, and they're going to pick whichever supplement maybe they've heard about an advertisement for. This is kind of what's going on in your patient's mind. I want to talk about 5 supplements here that are very common that I think are critical for primary care providers to know, at least the basics of. First, let's talk about a multivitamin. On the left, you see the classical composition of Centrum Silver, one of the most common supplements these days. I know you can't really see too closely, but it has a lot of stuff. The question is, do we really need all of those ingredients every day? So per the CDC, as of 2020, 32% of Americans take multivitamin. But in a well-balanced diet, most Americans truly don't need a multivitamin. Even if they did need multivitamin, there's no such thing as a one-size-fits-all vitamin because all of our bodies require different things based on our body size, based on our microbiome, based on our individual diets. Oftentimes, these multivitamins contain unnecessary compounds, such as therapeutic, even toxic doses of heavy metals if you're taking this every day. A large analysis of data from nearly 400,000 healthy US adults all over 20 years found no association between regular multivitamin use and lower risk of death. So overall, through various consensus statements, multivitamins are generally recommended against unless a patient that has a poor diet that's not comprehensive. Next, I want to talk about vitamin D. A lot of us check vitamin D every year. We know vitamin deficiency is associated with morbidity and mortality. What exactly does the data show? So 42% of Americans were deficient in vitamin D in 2011. 18% of Americans take a vitamin D supplement. I feel like we test for vitamin D a lot. But what is the actual screening recommendation? So it's recommended to test for vitamin D in those with high risk, such as osteoporosis, obesity, chronic disease affecting absorption, low sunlight exposure, or other high-risk groups. Notably, a couple high-risk groups there are non-Hispanic Black Americans, women, individuals aged 20 to 29, the winter season, those who avoid dairy, obese patients, and patients with high blood pressure. So if you are taking vitamin D, it's important to take a supplement that has vitamin D and calcium with the goal of getting your levels above 30 to prevent complications from osteoporosis. So there's a lot of buzz on vitamin D longevity. There's a lot of data that suggests low vitamin D is associated correlation with cardiovascular disease, cancer, and all-cause mortality. In 2014, a meta-analysis of 8 prospective cohort studies, over 26,000 participants, showed that those with low vitamin D had a 57% increased risk of all-cause mortality to those with adequate levels. However, randomized controlled trials have generated less optimism. The Hallmark Vital trial randomized 25,000 participants, and found no significant reduction with vitamin D supplementation over 5 years in mortality. There may be a small benefit in those with a low baseline, but I think this goes to show the idea of an illusory correlation. The idea that just because there's an association between A and B, A may not cause B, A may be a surrogate for something else. So perhaps how we get our vitamin D levels is important, as opposed to artificially chasing a number with a supplement. The next supplement that I'm a strong advocate of is magnesium. Up to 50% of patients are magnesium deficient. Magnesium has tons of utility, including functions as a laxative, to help sleep, to improve anxiety, depression, muscle recovery, to improve brain health, and even improve insulin resistance. Common dosing is about 400 milligrams of compounded vitamin D. There are some contraindications, active diarrhea or GI distress, myasthenia gravis. Some special populations that have an increased demand for magnesium includes alcoholics, athletes, absorptive disorders, and patients taking PPIs or on diuretics. Interestingly, the food with the highest magnesium content by far is pumpkin seeds. So vitamin D has a
So
lot.
I eat like all the pumpkin
Yeah,
seeds
you
that I
know,
roast, does that mean that like I'm overdosing on magnesium?
So the good part.
Because I am the one in my family that eats like all the pumpkin seeds that I roast.
Yeah. So the interesting thing is some foods actually lose a lot of nutrients. They become less bioavailable if you cook them. Some become more bioavailable if you cook them. I haven't memorized what happens
Yeah.
with pumpkin seeds. I think it's roasting, and then like, what are we roasting them with? Roasting, those are all really important considerations.
Olive oil
There we go.
and actually, extra virgin olive
There we go.
oil.
So magnesium has a ton of functions up there. There are some sources of magnesium. It also has a lot of neurological effects as well through a couple of really interesting mechanisms. It modulates brain-derived neurotrophic factor, which is the principal biomolecular vehicle of neuroplasticity. This contributes to protection of the blood-brain barrier, which is critical in the development of neurodegenerative diseases. It's important in maintaining ionic homeostasis. It affects NMDAR blocking, and if you recall, from my memory, I do believe that is a subtype of the glutaminergic kind of receptor. So it inhibits a lot of the excitotoxicity of basal glutamate function, which is good. It antagonizes calcium as both divalent cations. They both compete for similar transporters. So as we recall, calcium is the end product of the action potential, which leads to the vesicle stopping on the next neuron. So having less of those firing can be beneficial for a lot of diseases of over-excitation, like anxiety. And it also has some effects on GABA, actually. It helps agonize some of those receptors. So let's talk about some data. So I talked a pretty big game. I said magnesium does all those things. Well, what does the literature show? Let's start in the top left with respect to magnesium's beneficial effect on insulin resistance. So in 2024, a triple-blind RCT of those with PCOS, which is a common complication of insulin resistance, those randomized to 250 milligrams of magnesium had lower insulin resistance at 2 months and at 6 months. Another study showed that after adjusting for age, sex, energy intake, compared to those with the lowest magnesium intake, not Dr. Firehouse, of course, those with the highest intake,
After Halloween, at least.
those with the highest intake had a 37% lower risk of instant metabolic impairment, and those with baseline metabolic impairments. Next, let's go down. Let's talk about cognition. So, in a cross-sectional study of 1,000 geriatric populations, patients, serum magnesium was inversely associated with a high risk of MCI, as well as differences in attention, executive function, and language ability. In a big study from 2011 to 2014, it showed that higher dietary intake of magnesium independently correlated with higher cognitive scores. It also is a known benefit for digestive health. We know magnesium oxide is a great laxative. Magnesium also has a strong role in treating chronic pain. Higher magnesium intake is associated with a lower likelihood of developing chronic pain after controlling for socioeconomic status and many other clinical factors. A systematic review shared multiple randomized controlled trial results of magnesium supplementation having a beneficial role in post-operative pain, neuropathic pain, post-herpetic neuralgia, dysmenorrhea, and even tension headaches. There's more. So, if we start at the top, magnesium is a powerful sleep agent. Yesterday in our academic half day, we talked about sleep management in the geriatric population. And the moral of the story is there's not much. There's not many good medications. So what's the role of magnesium? So as an antagonist to the excitatory NMDA, and as an agonist to the inhibitory GABA, magnesium has been shown in RCT trial and trial again to increase sleep time, sleep efficiency, endogenous melatonin secretion, sleep onset latency, and serum cortisol concentration, as well as minimize early morning awakenings. Going clockwise here, a meta-analysis of 7 RCTs looked at magnesium supplementation and depression, and they found that magnesium use overall reduces depression severity. In terms of exercise performance, your muscles need magnesium too, and it's been shown to improve performance, expedite recovery, and have a protective effect on muscle damage after intensive exercise. It's also been shown to lower inflammation by looking at a lot of those inflammatory markers, such as fibrinogen, CRP, TNF, IL-1, as well as increased nitric oxide production, which is critical for arterial health. Creatine. So creatine is a amino acid derivative that is probably the most well-studied supplement out these days. Common uses include exercise performance and brain health. It actually has a really interesting biochemistry. So creatine is rapidly converted to phosphocreatine by creatine kinase. That phosphocreatine is then an accessible phosphate group for ATP in the cell at the threshold of anaerobic and aerobic respiration. So essentially, the way I like to think of it is at the last moment when your cell loses its ATP stores in the cell, phosphocreatine then gives it an additional ATP to allow for that extra set or that extra rep in that physical performance. That extra set is where the hypertrophy occurs. So this helps you get that last rep in. Dosing revolves around 5 to 10 grams a day. There are some special considerations. Creatine does degrade into creatinine, so it probably would be a good idea to get a baseline creatinine in the patient before starting this. It also is a little bit osmotically active. This has been a myth for a very long time, but it was debunked among several meta-analyses. Creatine is a little bit osmotically active, so there's a small chance of short-term water retention. So there is kind of a yellow light in terms of patients who are volume sensitive, at least initially. So creatine and exercise performance. What does the literature actually show? So I cited Wax et al., which is 2021, one of the biggest scoping review of over 500 articles on creatine, and it actually showed very consistent results. Creatine supplementation exerts positive ergogenic or increased performance effects on single and multiple bouts of short duration, high intensity exercise activities. It has to do with it helps it affects maximal strength, maximum work output, power production, sprint performance. It increases fat-free mass. It speeds up recovery time. Moving over to the right side of the screen, Wax et al. Cited another analysis of 22 studies on resistance training, and it showed that on average, it increases relative muscle strength by 8% greater than from resistance training alone in randomized trials. Another study showed a 14% increase in muscular endurance to those randomized to creatine versus placebo. And another systematic review identified 60 studies that met the criteria of randomized control trial design that utilized a double-blind placebo-controlled approach that looked at the effects of creatine on lower limb performance, which looked at each muscle in the lower limb individually and showed that each of those muscles has a beneficial performance benefit. Now, what about people that don't actively exercise? What's the role of creatine for them? So in untrained populations, the improvement is 20 to 25% muscular strength in untrained females supplementing with creatine while undergoing 10 weeks of concurrent strength training. So even if you're starting from scratch, there's a lot to be gained. Creatine has also been shown to have nootropic or cognitive boosting capacity. So in a recent meta-analysis by Zhu et al. In 2024, it looked at 16 RCTs with about 500 participants across all age groups, 20 to 75, taking creatine monohydrate, and it was found to have significant positive effects on memory, attention time, and processing speed, but no overall impact on overall or composite cognition or executive function. Subgroup analyses revealed that some groups were more susceptible to this, such as those aged 18 to 60, as well as females. No significant differences were found in short or long-term duration. So that may suggest that you may get the benefits sooner rather than, or sooner as well as later. And then just to kind of attenuate these results, put them into perspective, Zhu et al. Did do a quality measure. They talked about there's a low to moderate risk of bias was found with no significant publication bias detected. Um, keeping the ball rolling, the last supplement we're going to talk about is CoQ10. So CoQ10 is a molecule endogenously created that functions in the electron transport chain. So it helps the body derive energy from glucose in mitochondria, but it also has many antioxidant effects as well. There's two kinds of CoQ10. There's ubiquinone or ubiquinol. Dosages are 100 to 200 every day. Ubiquinone is much more bioavailable and has much more data to support it than ubiquinol in head-to-head trials. So the physiological role in its mitochondrial bioenergetics has led it to be a potential candidate for the treatment of various diseases that are related to oxidative stress. Aging, statins, and genetics can reduce CoQ10 levels, and low CoQ10 levels are associated with cancer, diabetes, cardiovascular disease. So we know that there's an association, but in randomized controlled trials, does CoQ10 supplementation improve these diseases? So the answer is it does in many disease states. So in hypertension, in RCT in 80 patients with systolic hypertension, those randomized to 60 milligrams of CoQ10, which is quite a petite dose. They had a 17 millimeter mercury drop in systolic blood pressure after 12 weeks. A review of 3 RCTs after this substantiated the hypertensive benefits of CoQ10 and extended the benefits of diastolic blood pressure as well. Notably, in those with heart failure, it was not associated with hypotension. So it seems to have an effect of bringing closer to physiological blood pressure levels as opposed to the hypotensive effects. Second, there's a lot of data on CoQ10 and ischemic heart disease. So they looked at LV systolic dysfunction and secondary ischemic heart disease, and they randomized patients to CoQ10 for 8 weeks. They looked at a measure called flow median dilation, which is the amount that your blood vessels dilate after constriction, and it correlates directly to endothelial function. And they also looked at mitochondrial function through various metrics of metabolism, and they found out that CoQ10 supplementation improves endothelial and mitochondrial function, and is therefore associated with theoretically better ischemic heart disease outcomes. Further, statin-induced myopathy. A recent meta-analysis of randomized controlled trials published in the Journal of the American Heart Association endorsed that CoQ10 supplementation ameliorated statin-associated muscle pain, weakness, and cramping. The big hallmark study in CoQ10 is called the Q-Symbio study. This is a multi-center RCT of over 400 patients with moderate to severe heart failure, currently on standard therapy. They randomized patients to 100 milligrams of CoQ10 3 times a day or a placebo for 2 years. They had short-term and they had long-term outcomes. The short-term outcomes were changes to the NYHA functional classification, the 6-minute walk test, as well as BNP. And the long-term endpoint was 2-year composite major adverse cardiovascular events. So what did randomized supplementation of CoQ10 show for these heart failure outcomes? I know it's a little small there, but as you can see from my text over there, that the primary long-term endpoint, so that's maximally adverse cardiac events, right, was reached by 15%. So there were 15% of patients in the CoQ10 had these negative outcomes, whereas 26% in the placebo group had those outcomes. So that's a hazard ratio of about 0.5 based on how the statistics are calculated by an intention to treat analysis. With respect to secondary outcomes, cardiovascular mortality, there was a 9% versus 16% difference. Hospital stays, there was a significant 10 to 18% as well as NYHA class difference too after 2 years. And that's evidenced by the forest plot on the left, as well as those curves in the middle, A and B. CoQ10 is also well evident for fatigue as well. In SciEdal in 2022, they published a meta-analysis of 13 RCTs of over 1,100 patients. These patients included healthy people, healthy participants with fatigue, end-stage renal disease, heart failure, multiple sclerosis, and fibromyalgia. Overall, CoQ10 in a dose-dependent manner reduced fatigue symptoms. And there was no statistically significant difference in the adverse effect profile in either group. It's not currently recommended by the American Heart Association or the Cardiological but I do think CoQ10 is a very promising intervention with a minimal risk profile that I think could have a significant benefits once more data comes out. So a quick safety profile. So our review article investigated 20 years of data on CoQ10 on animals, and it suggested that the safe upper limit is 1,200 milligrams per day. It has no endogenous effects or no effects on the endogenous synthesis of CoQ10. It does share some structural similarity with vitamin K, so it could increase the metabolism of a drug like warfarin through the P450 system. A quick note on the placebo effects, which is very relevant when we don't exactly know what's in a lot of the supplements patients are taking. So the placebo effect is an inert substance that has been shown to trigger a series of neurohormonal responses in the brain of patients and healthy subjects that could have an anatomical and physiological basis. So there have been tons of fMRI studies on patients with pain given placebo treatments, and they saw that those given placebo versus a nocebo, they saw differential connectivity in different parts of the brain that control emotion and pain, and it actually is mechanistically derived through the endogenous opiate system. Placebos can reinforce or reduce the effects produced by pharmacotherapy or other therapies through a patient's positive expectations. And this has been shown in trials of fentanyl or caffeine, um, depending on how they are framed and perceived by the patient. So some conclusions. Supplements are physiologically active compounds that are widely accessible, and there's a growing demand of them. Patients have supplements on their medications. We have to be aware of the harmful effects of them, the therapeutic potential of them, as well as financial considerations as well. Um, we always have to emphasize the STEP approach, safety, tolerability, efficacy, and price. Safety being number one. Oh, and then here's one other slide on the placebo effect. There's a lot of different components of the placebo effect. The packaging, size, color, and flavor that it's supplements distributed. The fact that certain patients can by default be placebo responders versus non-responders, and then the relationship between the physician and the patient, that trust component. So there's external context, internal context, and I think it's important for physicians to be the leaders of this, as opposed to it being kind of a marketing component from brand commercials and that kind of thing. So that's where we are. I want to thank Dr. Mr. Monday for moving the slides over, Dr. Ray Mark for giving me the opportunity, and everyone for listening to me ramble about supplements.
All right, questions for Mark. You got a great resource. Let's get started.
So for folks who are supplementing with creatine, is there an alternate marker than creatinine? Do we look at cystatin C instead, or?
Yeah. So from my understanding, the increase in creatinine tends to go up a little bit and then it levels off. So as long as I would call that their new baseline, but I actually don't know if cystatin C is affected by creatine. I would think it doesn't. But overall, I mean, there are other markers that you function, PPC, fun. So I really think that's to be appreciated nowadays.
And you know, Russ, how long after you stop supplementation or creatinine comes back down?
I actually didn't. Yeah, hey.
Hey, how do you decide? I guess magnesium. We're talking about all the benefits, especially for people who are older. Do you check a magnesium level before you prescribe it, or do you just kind of prescribe it for everyone, or how do you decide?
So practicing inpatient medicine, you know how hard it is to actually complete magnesium. So I don't necessarily think for something as benign as magnesium to check a baseline is that important. Um, because just taking like 400 of magnesium every day is barely going to bring most patients above the super therapeutic range, just because the bioavailability isn't so great. So I don't think that checking certain magnesium level is essential. I do think it's important to track it annually because the purity of supplements, dependent. However, there are certain populations that are high risk for magnesium deficiency. So I do think magnesium screening in patients that have some from alcoholism is important. One interesting mechanism is magnesium reabsorption in nephron is thiamine dependent. So if the patient doesn't have thiamine, they're very likely to be hypomagnesemia. So in that population, I would say it's an indication to get a baseline. It also depends like your purpose of supplementation. So if your supplementation is to improve bowel habits, improve sleep or anxiety, versus depleting the magnesium, then I think that would impact your decision making baseline.
Thank you for talking through this. It's interesting like how many patients bring this up, even at DHP. How many of my patients take vinegar for blood pressure? What are you talking about? But I did want to ask, because I feel like I have started to see more people on magnesium, and then I've even prescribed it for headache prevention, and I think there's good uses of it. But sometimes when I try to prescribe it, even for those that need it at a certain level for heart disease or whatever, it's oftentimes considered an OTC, and then you have to tell the patient to get it over the counter, and then how do you trust what you're having them go down the aisle to purchase versus like what you're getting from behind the counter at pharmacy? Like was there any guidance on how to counsel patients on looking at the label and figuring out what's truly in that supplement they're buying?
So exactly.
We'll go ahead and do dessert.
Sorry.
No, that's fine.
You have a dessert mentor?
But y'all keep going.
Sure. You want it to go?
Yeah, you get something to go.
Today it's vanilla. You sure can. Anything for you, sir? You sure can. Do you want a box for yourself, child? Anything for you, ma'am? You want that ice cream? You better cut me off. Dessert for you, sir? Do you want it for here to go?
I'll do
I'll grab some for you.
What's the teacher's cobbler today?
Apple and
Oh, really? I'll get that. Thank you so much.
Do you want it for here?
I think that would be great. Thank you.
What fruit would she have had to say? Or should we just say no?
The apple cobbler.
Fruit
cobbler.
How regularly is seen and with the Monday,
I don't know about that. WebMD also has a section where they review this kind of thing. Up to Date's also a pretty good resource. 99X, I had limited success.
So the other resource I found is like the NIH website. So we have an NIH supplements website that I use, and they're pretty comprehensive because we had patients that were taking like testosterone supplements, and then sometimes they put like caffeine or stuff like that in there, you might not know. So that NIH supplement website is also really nice.
So in addition to being alcoholics, this couple that I was talking about, the woman is definitely in that bar of like little knowledge but high confidence, but I think she stays there. And so her supplement regimen was nutso. And she's about to do the 4th ivermectin cleanse on her 7-year-old son with autism because he becomes so much brighter and more verbal after it. So like, I'm like, this is the trip where I just don't say anything.
Who's prescribing the ivermectin?
I have no idea.
I know you are a doctor.
Yeah.
Probably why she brought it up. Like,
Because she is so confident.
yeah.
It is really interesting. She is so confident in her knowledge. It was really interesting. So I learned a lot of I learned a lot about various supplements and treatments, but I was like, holy cow.
Mark, I have a suggestion for
Yes.
presentation. I wanna section.
My
Like,
supplement drawer section. Yeah, I mean, the first thing that I recommend if you're thinking of starting a supplement is you probably don't need much. Like, I don't think anybody should start a supplement just because they want to start something. A lot of people feel like in direction in life, they need a little some spice in their life. Maybe they've had a tough month at work. Maybe they're not sleeping right. I think the first thing to do is rule out, like, go to the doctor and like, do it. Go to the doctor. Go to the doctor and just have an objective sense. But so your question was like, what supplements? So how do you go about starting? Like, thinking about that. First thing is like depleting deficiencies. So like look for the common things. If you think if you have a suspicion, right? So your vitamin D, your B12, that kind of thing. And then if you really have a problem like with sleep or like heart health, I would recommend go to the doctor and see what the doctor has to say before starting a supplement. That being said, as like if I'm recommending physicians this kind of thing, it all comes down to like STEP, right? Safety, tolerability, efficacy, and price. And each person's individual weighing those things determines their own decision. So safety is the number one thing. So if you do your examine search or WebMD or what was the NIH website, and it comes in safe, and that safety profile data includes your individual, like you represented in that safety profile over a certain amount of time at certain dosages, then I think that's the most important thing. And then you could try something, make sure you get the most bioavailable form, maybe try it every other day, or you try one every once in a while, and then don't just take something for years and years. That's just all that inertia, right? See if you really need it. That kind of thing.
with the CoQ10 for staph myopathy, do you know, were they already having symptoms of staph myopathy or they just started at the same time?
I actually don't know. Yeah.
And I mean, it wasn't in this presentation, but have you came across any thing for testosterone supplements? Because you know a lot of men, especially for like energy and fatigue, take these over
Yeah. So the whole, I mean, you probably know about this tonight because it's endocrine, but the whole like the hormone axis is very complicated. A lot of the supplements have very interesting mechanisms, whether they're like secretagogue, HCG, or they act as a luteinizing hormone.
Perhaps more
There
to think
is
about
some
that.
efficacy in some of them, and that could be problematic because we know stuff like it's not a very substance, as well as the contaminations with other things. So I don't recommend getting over the counter supplement or like androgen supplement, but like the data for some of those things actually seems relatively robust.
Did you already say what your go-to fruit was?
My go-to fruit. Oh, so I asked what peach cobbler flavor was, and then Dr. Alexander asked me what flavor she would have said would make me not get cobbler, and I said something none.
But which fruit out there has the most nutritional value?
That's a great question.
The berries, the
It's
sauerkraut.
Oh.
Yeah. So berry. So I mean, it comes down to the glycemic. So you know arm, right? So which berry? So some fruits have a higher glycemic load than others. So watermelon is notorious for raising blood sugar levels. Grapes as well. So not all food groups are equal. Just because the pyramid was built first when we were kids doesn't mean the nutritional biochemistry mirrors that. So everyone has a different glucotype, it's a whole separate discussion. The berries typically have great antioxidant, great glycemic.
Mark, what do you think about pomegranate juice?
Sounds like y'all had this conversation before.
Yeah. It has a glycemic promoting effect in some populations. Very similar to apple cider vinegar. I think it has to do with like anyway.
Nice.
Someone made me look up the apple cider vinegar has a peptic ulcer disease gastritis association.
I think it depends how you take it. So I think if you take shots of apple cider vinegar, your risks are higher as opposed to gummies or pills, depending on where it's released in the GI tract. Yeah, I've seen a lot of the data. So it works at the transient effect. So they think warm meal lowers your blood sugar, like lowers this peaks of the blood sugar and brings it down faster.
Yeah.
Sorry.
Yeah.
She says yes. What's that? I hope she says yes.
that's the physiology, but there's been no data suggesting it actually makes the patient see if you take it every day.
Don't become hypoglycemic on us.
Yeah, right?
Just do like the compared like 2 hour and like 4 hour glucose tolerance before you see the actual maybe that's more
So Mark, so you don't like multivitamins?
It's not that I don't like them. The literature suggests.
But is it something else that people walk in
Mhm.
and you see that as something they're taking that you cringe? That are high on your list is, this is definitely something you should not be taking.
So, I think the dose makes the poison, right? So, one thing that I see all the time is zinc. Extraordinarily high levels of zinc. Especially as flu season comes around, if you walk to the Walgreens across the street from the hospital, there's a giant pyramid of zinc. Giant pyramid. Now, buy one, get one free at remarkably super therapeutic doses. So, I do think that the dose makes the poison. So, I think the dosage scares me a little bit more than the actual thing. There are some things that shouldn't be on the market. Like as Seth was mentioning before, like any hormone, over-the-counter hormonal medication, that's such a complicated physiology. It has to pass kind of the sniff test for me in terms of like, is it simple enough to, relatively simple enough of a mechanism for me to be able to appreciate their comorbidity. So yeah, that's kind of what I think.
How did we get to where we are now? The FDA not even. I mean, talk about consumerism and the amount of. I don't know, just with the congressman, like not even lobbying for the supplement industry that the FDA can't even regulate. Doesn't.
Can't keep up. There's like so many products out there that you barely keep up with actual prescription medicine.
I just find it so interesting. Like, I have patients that they refuse to take metformin.
Oh,
They're
yeah,
like,
so
oh,
many,
metformin
yeah.
has like cancer-causing agents in
Yeah.
it, but yet they, will buy so many supplements.
Yeah.
And there was, I think I might have messaged you about this more, but like, wasn't it melatonin where they did this big study?
So I had some
like
extra
kids,
slides. Yeah.
kids were on
Wanna
melatonin
put
for
PowerPoint
sleep.
back up?
Yeah.
I have a slide.
There's like THC in melatonin or something,
Yeah,
right?
CBD.
CBD, yeah.
Oh,
I don't know.
yeah. I'll
And
show you.
unwanted ingredients in melatonin.
So scroll a little bit past.
But it is so interesting that like people don't take our prescribed medications.
Right. So it's click up one more.
This one?
Up one more. One more up.
Oh.
Yep. Thanks. Up one more.
Do you remember this lady?
Yep. So I have a what's the physiological dose of endogenous melatonin, and you guys know.
Like 0.1.
Yeah, point one, right?
Like
So,
0.1. They were telling me to take
yeah. So
10 milligrams.
skip to the next slide, please. Oh, I have nothing here. So the average adult pineal gland produces between 0.1 and 0.3 milligrams a day of melatonin. So in a real-world analysis published by JAMA of 25 over-the-counter melatonin supplements, the actual quantity of melatonin ranged from 3/4 of that dose to 350% of label quality. 80% was inaccurately labeled, and only 3 products that contained melatonin that was within 10% of the label quality. So the dose makes the poison. A lot of the safety data is on doses that are a little bit above the recommended daily allowance. And we have to prioritize third-party tested supplements. If you actually pull up the study, there was actually CBD in these gummies. And these are gummies that were tailored to kids. So, look, I mean, sleep is critical for, I'm not a pediatrician or anything, but I know sleep is pretty important for kids. It's responsible for their growth axes. And if you're messing up their endogenous sleep cycle with these pharmacoactive, super therapeutic elephantine doses, that can be problematic on the future of America. So, the future of America, one strategy that some people recommend is getting supplements from Canada, Canadian companies, because Canada's supplement industry is a little more regulated than us. So that's one recommendation.
So when did you have time to read all these slides?
That's the key question.
Yeah. That is a question. Well, you do a little bit every day. And if you find that you're passionate in, it's just who you are, right? So a lot of these slides
He's passionate about power.
Yeah. So, no, I mean, you know, I think we all should be empowered by what we put in our bodies. And sometimes prescription medication isn't the right answer, right? So I think, right, this is real world medicine. So patients, whatever you specialize in, are going to be on supplements. Your family's going to ask you about things. It's going to be in the news. I think it's important to know. I enjoy this.
Mark, I saw some article, I think some like younger man like died recently, like in Colorado from like kratom, I think supplement.
So,
I've never heard of that before, but I just saw a sign driving by. I think
kratom is like a legal, like partial opiate.
Yeah.
So I mean, this is like you're taking supplements for medical purposes. I mean, the drug, like legal like psychotropic market is ridiculous. So I was in Nashville 2 years ago, and there's a kava bar, like a kava, which is a remarkably hepatotoxic psychotropic substance, and they're like marketing like outside the bar with like a white coat on, trying to convince people to pamphlet about health benefits. And in my head, I thought, this is so bad, man. But kratom too is just very dangerous. So our government allows that stuff to be legal, but it's tough. Safety, tolerability at the price. Safety.
I mean, I will say this, Kava, right? Yeah. You know, Polynesian people, a certain group of indigenous people have been using that for many, many years. So, I guess, back to your point about dosage and ways that it's all about preparation. Maybe not everything's evil.
Sure.
Yeah.
Ray, do you have patients bring in interesting supplements to ask you about?
So, well, not too crazy. I mean, and one thing I have started doing is I'll actually, when I do my assessment plan, the first bullet point I'll usually make now is vitamins. And at least if they're physical, I always make it a point to ask people what exactly are you taking over the counter, because it's never represented on their med list, and it constantly changes. And it helps me when I do my labs to sort of see what people might be deficient in or not deficient in. Yeah, and so sometimes people will list things I've never heard of or don't know. But the ones Mark said, I mean, it's a lot of magnesium. Here recently, a lot of creatine. CoEnzyme Q10 seems to come and go, and it seems to get popular and fall off some. Yeah, it sort of seems to have died down for some reason. Then a lot of vitamin D, a lot of B12. I mean, it seems to be sort of the routine. And then every now and then somebody will come in and they're taking like bladder whack or like really weird things that I've never really heard of, to tell you the honest truth. And I've sort of made it my principle. I never really demean vitamins. People really seem to buy into them. There seems to be a huge placebo effect, and folks often will say, I feel great since I've been on this. There's something called Plexus. It's some vitamin company that sells vitamins that cure everything. And I saw a lady the other day, and she's like miserable, chronic fatigue, bowel problems. She started on Plexus. They a lot of this you find they actually sell in churches. Yeah, there's a huge market within the church community, especially evangelical, a lot of evangelical churches. Somebody within the church will become affiliated with an organization, and then of course they'll sell it to their Sunday school class, and it just gets propagated within there. And so somebody in her church was selling Plexus, and it is a miracle from God. But she feels so much better since she started Plexus. And I have no idea what's in it, but I would have been probably would have been foolish maybe to tell her you should really stop taking Plexus. So yeah, I sort of made it a habit not to, like say you're completely crazy for taking a lot of that stuff. People they really buy into it incredibly strong. I mean, my father-in-law, he's always on Facebook, and some bullet will pop, something will pop up, and he says, why have I not been taking that? That stuff makes you live forever. And he'll click on it and order it. And like every week, he's ordering, something new to.
Some of my patients ordered something like sciatic ease or something off of Facebook, and now she's got a subscription to it.
Yeah. So it's almost out there, and for us to try to back that down just seems completely impossible at this point. But then I have had cases where the classic one I always say is there's another company called Life Extension, and they prioritize older people, advertising to older people with money, retired people with money, and they have a great website, and it's it's good because it's expensive, right? It's got to be good because it's pretty expensive. It's the way people think about it. And I remember seeing a fella, and he came in, his liver function was pretty elevated, and we were talking, do you take any vitamins? And he says, yeah, I take a couple vitamins. I said, well, bring him in next time. And he comes in with a suitcase, literal suitcase, big suitcase, and he opens it up, and it is just full of vitamins. And he was sort of in this situation where he just kept ordering more and more and more. And we just stopped everything, and his labs went back to normal, and it was obvious he was on, I don't know what it was. But that was a fella that just sort of got bought into this movement to where as he started taking something, they would say, well, this will make you live. It was life extension. It wasn't that it made you feel better. All this made you live longer. So, I mean, cases like that, even he saw this is crazy. And you could show him his labs and all this is bad for you. And even he realized that this was a bad idea. For most people to try to convince them that it's bad is going to waste too much of your time. Don't you think, Mark?
Time ruin your relationship.
Yeah, ruin your relationship. So I'm very accepting, but I don't know the doses that well. To tell you the truth, that's one thing I probably need to learn more about the dosing. And honestly, what I do lots of times when they come in is I look them up on our Walmart app, and I'll see what's available at Walmart. And if it seems pretty, like CoEnzyme Q10 is 100 milligrams at Walmart. So 100 milligrams must be a safe dose, right? Is that true? Is it? Is that?
Yeah.
That's a pretty reasonable dose for it. Because it seems like a lot of the mega doses you have to go outside of that, like GNC or order them online.
Sometimes melatonin.
Yeah, melatonin. You get.
Yeah, I would say it definitely varies, but that's generally a good rule of thumb.
If they have it at Walmart, it's safe. Right? Is that true?
Thanks, Samuel.
Thanks, Walmart.
Yeah.
So.
You can say that about Amazon.
Yeah. Dr. Liz and I don't know if you guys have had patients come in from the integrative medicine department that got shut down in the past.
Yeah. Oh yeah.
But when I was in endocrine clinic, we had this one patient that came in who used to be a patient of the integrative medicine, and they were on some supplements for thyroid hormone replacement that we absolutely had no idea about, what it was.
Did they get shut down?
They got shut down by Asian Health.
Because of this supplementation?
I'm not sure, but with the merging, they got shut down. They got 1 week notice, and then they shut it down. But anyway, I'm just curious, if you guys have seen any of the patients from that department that come in with these weird supplements.
So I didn't see it as much from ours. They seem fairly reasonable, to tell you the truth, comparatively. And Atrium down in Charlotte, they've actually got an integrative health clinic down there. Yeah, we still don't know what happened to the one here, to tell you the truth. But some of the other Robin Hood integrative medicine and some of the more popular integrative medicine clinics here, a a lot of it, and you talk to patients, and a lot of it is you go in and you see them, and they assess your health, and you've got multiple problems, and they do a lot of really weird blood work. That's always abnormal. Everything's abnormal, and they say you need these things, and then you walk to the counter and you buy them, right? So I mean, it's always a little bit of a weird scenario where doctors aren't allowed to own pharmacies, right? So I can't prescribe something and then sell it to them, sort of be legal. But that's sort of the business model within integrative medicine is you stock them and you recommend them and then you end up selling them. And so there's always this weird, because so people end up on a lot of vitamins that go to integrative medicine clinics and pretty high doses of vitamins. And we do see people that will come in. It's not uncommon to have somebody over the years with AFib go to the emergency department and they're in AFib and they're going to Robin Hood Integrative Medicine and they're on a lot of thyroid supplementation. And you immediately stop their thyroid supplementation. So you do get a lot of that. But it's not. I mean, honestly, it's not every single person that goes gets into trouble, and we have a lot of people that go to integrative medicine around here and really buy into it. I mean, we do the executive health clinic downstairs, and you would be shocked how many executives are plugged into that system. Oh yeah.
Two patients from GHB that had gone there were going for acupuncture and massage, and they had great benefit from that because they took Medicaid for acupuncture.
Wow.
Which was nice. That was a nice service.
Yeah, that was a great service for some people.
Have you seen the literature on acupuncture?
Training in San Francisco, there was a big push on acupuncture.
So in my most recent book about a year ago, about half the literature says it's good, half the literature says it's not bad. But it's safe, tolerable, effective, so why not?
Yeah. I will say my neighbor's dog got acupuncture, and that dog looked like it was on its literal last leg. Like, could barely walk. And then the next day we see him like running around outside. And I was like, what happened to your dog? Like, I thought it was dying. So like, we found this vet that does acupuncture. Like a brand new dog now. Apparently the vets are getting in that.
So there's a animal chiropractor.
Yeah. Like large animal, you like giraffe neck.
No.
Oh my god. Yeah, I've seen like TikToks really.
On TikTok, I went around doing that.
Today I had a patient on a silver nasal spray. She's very cuckoo about my fluticasone, but the silver nasal spray. I did not know.
I am always impressed though. I still feel like patients will bring things in or they'll get samples and I'm like, what do you think of this? And I'm always very it's very humbling. So I'm like, I've never even heard of this. But when they see, okay, let's look up all the ingredients, there is a little bit more empowerment or willingness to kind of figure out how it interfaces with the rest of their med list. So I'm always like, all right, if I can at least get them, they're going to be taking supplements, at least to bring it in so I can lay eyes and add it to the med list and know it might interact. So it seems like the interaction part, I've had better buy-in and convincing patients that it's not safe if I can show that it might interact with some of their other medicines.
I think it's really humbling, and it's so hard to say. I don't know what these are. They kind of, I feel like I struggle with losing their trust on it. I've never really heard of this supplement. And then also at DHB last year, I had a patient who I saw her one time, but this was a follow-up after a hospital visit where she bought a bunch of Brazilian seed from Amazon, and then they all got recalled. But then during that time, all of a sudden she just got really sick. Went to the hospital, had really bad drug-induced liver injury, just her LFTs were through the roof. They stopped it, and suddenly she got so much better. But then she brought in the seeds. So apparently they weren't Brazilian seed. Tiny little seeds. And I was like, how in the world would these little seeds cause such bad liver injury? But yeah, a bunch of them. Amazon had to recall all the Brazilian seeds. So really, really scary.
I had one patient bring me a pack of mushroom tea.
Oh, yeah.
Drinking,
Oh, yeah.
like that's another very
Instead of
popular.
coffee.
Yeah.
I definitely get the Instagram ads for that.
Really? Really know that you,
It's not a good option.
your garden you got going.
Yeah.
So mushroom intake is actually very, very interesting in terms of its effects on, like longitudinally with cognitive function in elderly adults. So the principal bioactive ingredient is called ergothioneine. Anyway, I don't have a slide for that. But mushroom supplementation is worth to be taken in those kind of manner. In retrospective studies associated with like less MCI in elderly adults. It's something mushrooms we just don't know. Does that mean we should be taking extracts that have the equivalent of 100 mushrooms in a little dropper? Probably not. But it does inform the idea that a well-balanced diet, right, is critical. And yeah, it's like, avoid the bad things, emphasize the good things, and things should probably work out.
So how much matcha would it take for me to get dilly?
So that's a fantastic question.
Did you plant this question?
I did.
I don't know the
It's
answer to
great.
that. But Celsius is 3D extract, and guess what? They don't say how much. So all I'm saying is that's not something we should drink every day.
I don't.
Yeah.
I've never even heard of it. That's yours?
Celsius,
Celsius?
yeah,
Yes.
Yeah.
it is an incredible energy drink. That works really well, and it tastes really good. And
It's different than 5 Hour Energy.
yes, 5 energy is just caffeine. So when it comes to energy drinks, it's often a cocktail and many things in this. Anyway, it's really
You
extra.
start asking people about their energy drink intake, but I'm saying like tachycardia
Well,
and,
seriously, like, we
and
had
hypertension.
like caffeine, like that, like speaking in that testosterone stuff, and we didn't know why it was like so like hard and so like it didn't like that's what they find medical school, but like we're like, yeah, what is going to do?
Yeah, I feel like I always ask about like caffeine intake, but I don't specifically ask about sports drinks or like energy drinks.
Pre-workout.
Yeah.
Don't forget the pre-workout.
So dangerous.
Do you guys ask about that? Like, which
Yeah.
I really do.
Thank you.
Whoa, it comes with ice
No, thank you so much. Appreciate it.
You're Yeah.
All right, guys, well, let's close up with door prizes. Here's the selections for this dinner. Riverbirch,
Here's banana pudding.
Little Richard's, care of Marc Perlman, Cracker Barrel, avocado, Amazon, Szechuan Palace, or the random $100 bill. You can make your choice. Here, we'll let Dr. Alexander. We'll let Dr. Alexander choose, and we shuffle these. Choose the number one first selection. It's pulling out and pulling out today.
Oh, okay. One piece of it, okay.
Yeah.
All right, first person.
Madeline.
I'll do the Amazon.
And
Wow. Nice. Thank
Joe,
you.
our Amazon. Look at that. All right. Second place winner. Shuffle them again. Okay, choose. Make your choice. Make your choice.
Next up is Seth.
Woo!
Okay, I'm gonna go with that $100 bill.
Yeah. What? We're gonna take a picture.
Okay, all right, do
You
that.
have the watermark to make sure.
Third,
Yeah.
third.
Right.
We have here.
Martin.
Woo!
Nice. All right.
Labuta.
Oh, nice one.
Pass it down, pass it
That's a
down.
lot of margaritas, man.
Two left.
Penultimate. Shannon.
Yay! Cracker Barrel?
Yeah. Love Cracker Barrel.
I love
I
Cracker
love
Barrel.
Cracker Barrel.
They have a gift shop. That's right.
I love the gift shop.
And then
There's
last.
a lot of Halloween things.
Last.
Marky Mark.
Mark. Good choice.
A little richer.
You bought it, you get it.
Ah.
Thank you, thank you. Thanks everybody for coming.
Thank you.
We'll do another one in 2 months.
Very cool. Can we take a group photo? We haven't had a group photo in a while, and you know, the recruitment season's coming upon us. We gotta show off how much fun, how many kids we want. Oh. Should we have Mark's slides in the background?
Yes.
Yeah, thank you.
Nice.
Let's see. Hey Ray, can you put it on the, this first slide? We can have it in the background, just show off,
All the fun that we
Dr. Perlman's, exciting
Yes,
tournament talk.
yes, yes.
Thanks for coordinating that.
Yeah, thank you for doing that, Mark.
We can set up this one.
Okay, that it?
I don't know, I'm not there yet. All right, I'll be in front of Mark's slides. Come on, Ray. Let's see if we can get it. Well, I don't know, Mark is like the selfie guy.
I'm not surprised you there anymore.
You are too. Come on now. Are you, let's go to the kitchen. Nice. Oh my God. I don't know. I don't know if my arm is.
Just grab some out of the crowd.
We always just chat.
Yeah, I know. I was trying out my arm. He's coming? Nice. Made it happen. Yeah. We can like middle.
We can.
Mark in the middle.
Yeah.
Here.
Yeah.
Yeah. There we go. I'm sorry, that's okay. You're fine. Okay. Thank you. You're welcome. We haven't had a picture in a while, so you know. Oh wait, I have like a full jacket on. Oh, you're good.